Welcome and thank you for making it to Saturday afternoon, day 2 of the conference. Appreciate everyone being here. We're going to dive right in because we have what seems like a jam-packed and very interesting session ahead. So session 7A, 5 years of treating perinatal substance use disorder at Kingston Health Sciences Centre by Dr. Adam Newman. I'm just going to introduce you here. Adam has practiced full-scope family medicine in Sioux Lookout in Kingston for 20 years before obtaining certification from the Canadian Association of Addiction Medicine in 2013. Since then, his practice has been focused on addiction medicine and harm reduction exclusively, including perinatal addictions and substance use. He is most responsible physician for opioid-dependent newborns rooming in with their mothers at Kingston Health Sciences Centre, where he also provides inpatient addiction medicine consultation and treatment. He has been in recovery from opioid use disorder since 2010. So welcome, are all so excited to hear you speak today, and I will hand it over. Thank you.
Hi, thanks very much, Katie. Thanks for inviting me. I'm pleased to be able to participate again in Medify. I can't say enough about how marvelous a resource and a support Medify has been, as I'm sure everybody here can attest to. I feel a little bit clueless because I don't actually know how many people are out there or what all of you do and what your interest is. I'm hoping to start off with a little bit of a case presentation, and I think depending on how many people were here, if it was less than 25, you should be able to speak up and ask and propose answers to any of the questions that come up in the case. If not, then I would just ask you to please participate through the chat. And as Katie said, I am a family physician in Kingston, and my practice is entirely focused on addiction medicine and harm reduction. And I do have some compromise in that I took some money once from Knight Therapeutics, but I will not be discussing their product, and I will try to only use generic names. What I wanted to do was first of all go through a case presentation and then hopefully guide it a little bit about what people say and what their interests are and what their needs are. I mean, the audience. I was going to talk a little bit about epidemiology of perinatal substance use disorder and then opioid use disorder specifically, because most of my focus, because of the nature of opioid use disorder and our ability to treat it, has been on specifically treating neonates in withdrawal from opioids. But as of course, I'm sure everybody knows, polysubstance use is very, very common. So we typically deal with, those of us in the rooming in team typically deal with women who are struggling with a variety of substances throughout their pregnancies. Opioid use disorder essentially serves as kind of a composite, sort of a proxy for substance use disorder in pregnancy. So talk a little bit about the effects of perinatal substance use, specifically opioid use on mother, fetus, and infant, and then our approach to treatment. And in doing that, I'll talk a little bit just about the experience that we had at KGH over the last 5 years. So here is a case. This occurred last year. So this is a 30-year-old woman flown down from the north to Kingston General, pregnant with what will be her 4th child. She's at 36 weeks, and she's got preterm pre-labor rupture of membranes, and she is accompanied by her partner. GBS status unknown. She's already got antibiotics running. We notice these are vitals and this sort of general picture. And I'm just going to jump forward a little bit because normally in a presentation like this, I would say, well, what are some of the reasons that a person might appear like this? And of course, this being a discussion about substance use disorder, you will already have been tipped off. This is about a woman who's in mild opioid withdrawal. So she's a little bit hypertensive and tachycardic. So she discloses, what happened was that she disclosed to the OB team who were looking after her. And I see that there are 34 people in the room, so thank you. And so we'll just stick with text. So as I just read this out, if anybody has any questions about any of this, please type them in, and I will add more information as we go. So she describes a use of Percocet up in her home community, and she says that she hadn't used for a couple of days, and she endorses that she actually feels unwell the way that she does when she runs out of pills. So we do a urine toxicology, a urine dip with point of care testing. It's positive for oxycodone, and it's negative for everything else. She did disclose that she has used methamphetamine at times, or speed, as she refers to it. So keep in mind, and this is an important environmental factor and socioeconomic factor, this woman comes from a fly-in reserve community. So in fact, while somebody disclosing that they use a couple of Percocet a day in Toronto or Kingston would sound a little bit dubious, and it doesn't really sound like this is a marker of severe addiction, often that's as good as you can get in communities up north. Percocet are few and far between. They're extremely expensive. That may be the only drug that's available. So the severity of a person's addiction, in my experience, doesn't correlate with the substance they use or the route of administration. So by now I've encountered many, many women who use opioids orally or crush them and snort them, and have not resorted to injection drug use because they simply don't have access to drugs that they can inject. And that's for the time being. I may be wrong. I'm sure there are many things are different in every different First Nations community, but so far the communities that we see people from down here in Kingston, this seems to be pretty typical. So this is the story, and she endorses. So remember, she is. To me, this is, I mean, if we remember, one of the reasons for rapid induction on methadone back in the days when that was our only agent for opioid agonist therapy was pregnancy. So pregnancy and HIV infection, right? Those were considered high risk. Pregnancy because of the risks to a woman of continuing to be in withdrawal if her opioid use disorder isn't treated. And the same holds true. This is precisely the problem. This woman is 34 weeks. It would be better for her and the baby for her to stay pregnant. We don't want her to be experiencing any withdrawal. So whereas in somebody who just says that their habit consists of a couple of Percocet a day, you might not think of opioid agonist therapy. In this case, she actually said that she would like to try it. She's familiar with it. There are people up in her community who are on it. And by it, I'm talking about opioid agonist therapy using buprenorphine, because methadone is not available in reserve communities. So she would like to try that. And at the same time, now these are the days of COVID, so her partner is not allowed in the room with her. He's outside. He's staying at the lodge in Kingston. But she says that he has also been using, and she would like him to be offered the choice because she feels that he is suffering in withdrawal. He is allowed to visit her. That's an important point, but he's not there at the moment. So as I'm interviewing her, she endorses she'd like to start OAT with buprenorphine, and I say, okay, we'll tell your partner to come to my office tomorrow, and I'll see him then, and we'll get him started. So day one. She has a significant COW score. We give her a bit of buprenorphine, naloxone, and her COW score diminishes a little bit. We give her a little bit more, it comes down further. So far we've given her 4 milligrams, and typically what we do the next day, we add together the PRN doses we needed. We give her 4 milligrams to begin with. And later that morning, typically what we would do is get the nurse to reassess the COW score about an hour after dosing. Oddly, it still seems rather high. I mean, this doesn't, maybe I'd be interested to hear about other people, but to me, this is high. This was as high as it was when she was in withdrawal and she first disclosed that she was in withdrawal. So although in the days when we would want people to be in withdrawal before giving them their first full therapeutic dose of buprenorphine in order to avoid precipitated withdrawal, we'd want a COW score higher than 8. In this case, it's significant. It's enough to put us in mind and worried about, make us worried about precipitous or preterm labor. So this is too high. We give her another dose, and her cow score comes down, and so far so good. So that goes on with her, but this second day is the same day that her partner first presents to my office. So he comes at noon, and the story that he gives corroborates what she said. He's also been an occasional methamphetamine user. He de-emphasized the amount of Percocet that he used. He said it wasn't really that much of a problem, and he didn't say he was in a lot of withdrawal. In fact, and his cow score was not very high. And again, at these levels of cows, I'm sure everybody else here has this experience. There's a lot of overlap with stress and anxiety, and it's very non-specific. A cow score of 5, a person could be irritable and fidgety and expressing a dysphoric mood just because they've flown down from their community. They're in a foreign city. They're talking to somebody in a language that isn't their first language. They're nervous about what's going to happen to the baby. That's not particularly indicative of opioid withdrawal. So he does give a urine sample, and lo and behold, it was positive buprenorphine. So the point of this that I wanted to, the reason I just presented this case was it indicates the family nature of addiction. So both of these partners identified a need to be treated. So he admits that not only was his partner concerned about him being in withdrawal, but that morning when he visited her at the hospital, remember, she was given 4 milligrams of buprenorphine, so two 2-milligram tablets. And we were surprised after that her cow score hadn't decreased. In fact, what happened was she gave one of those 2-milligram tablets to her partner because he was in withdrawal and she was distressed to see him that way. And she felt that he wasn't going to be supportive and able to be around and attentive to her if he's in withdrawal. So she divided up her dose and gave him half of it. So remember, this is, sorry, and I just wanted to remind you of that so you can see here, this is what I think happened. This is what I infer happened here. So we gave her 4 milligrams, her cow score didn't come down. We gave her another 2. So we thought now she's up to 6 milligrams. In fact, by this point, she's only had 4 milligrams in total because half of this she gave to him. So we appear to be giving her more than we are. So the partner is started on his own dose of buprenorphine naloxone dispensed by a community pharmacy, and he has to go twice a day. So because this is a low dose and he had already had 2 milligrams, I decided to give him another 2 milligrams, and he liked the idea of having it dispensed twice a day. And I think it also served a purpose. He's at loose ends in Kingston. He's at risk of being disoriented and feeling abandoned and lonely and bored. The fact that he had 2 trips to make to the pharmacy seemed useful to him. He wanted to be able to go to the pharmacy twice a day to be given his buprenorphine. Yeah, so that's what happens. And he gets better, and that's him. I'm just going to go a little bit further. Okay, so this is back to his pregnant partner. So on day 3, we give her 4 milligrams now, whereas recall that on day 2, the total we gave her on paper was 6 milligrams. So ordinarily we would have lumped that together and given her 6 milligrams on day 3. But in fact, we believe that it was only 4 milligrams that she took. So we give her 4 milligrams. We do the cow score a little bit later. Unfortunately, it was still quite high. So we underestimated how much she needed. We gave her another 4 milligrams. That came down. So the next day, we start her off at 8. So we didn't perseverate and stick to this idea that we were actually giving her 2 milligrams less than it said. We're trying now to just go by how she responds and what her cow score says. And eventually, she stabilizes at 12 milligrams once a day. And then the upshot of this, just what happens is that she finally, she stays pregnant for another 3 weeks. She delivered her baby vaginally. She's roomed in the hospital. Her partner was able to stay with her. They both received, he still had to leave the hospital to get his buprenorphine because he was not a hospital patient. She was dispensed in the hospital for the 5 days that she roomed in. The baby, she was able to cuddle and nurse the baby. The baby didn't require treatment with morphine. And they fly home together on day 7. So there. So that wasn't very interactive, but can I just ask, does anybody have any questions about that case specifically before I go into the main meat of the text? What the point of me doing this talk is because this has become a common issue and a not infrequent problem seen in the hospital. Some of the background, we've been aware for a while that women tend to use prescription opioids more frequently than men do. Many women with substance use disorder are of reproductive age. Many of the pregnancies that occur among women with opioid use disorder are unintentional. And there's the most recent data that I came across from a 2021 paper in pediatrics was that in North America, multiple studies have come up with rates around 5% reporting illicit substance use in pregnancy. And that illicit, sorry, go ahead.
Sorry, I was just going to point out that Julie Hunter did ask a question there. Why did the baby not go into neonatal withdrawal?
Thank you. That's a good question. So that's the whole point of my talk. Why did the baby not go into neonatal withdrawal? The baby did have neonatal withdrawal to a small degree, but it was treated entirely by being in its mother's company. So that's the whole point of rooming in. So rooming in doesn't decrease the incidence or doesn't decrease the likelihood that neonatal abstinence syndrome will occur and that a baby will manifest signs of withdrawal from opioids, but it almost invariably decreases the severity of the withdrawal symptoms that the baby feels, because the baby isn't also feeling stress from withdrawal from its mother. So typically, and this is, I will talk about this later on, this is the whole point of this discussion, was to institute rooming in as a means of treating and lessening the effects of rooming in. So this is just a little statistic, which is kind of cheap and doesn't really stand up to bright light. But so we talk about, well, why focus on opioid use in pregnancy? What's the big deal? Well, the death rate from opioid use is actually quite a bit higher than the maternal mortality rate. So of all the other things that we talk about that might cause death and morbidity in pregnant women, don't add up to in the population, don't add up to as many cases as cause mortality from opioid use. And of course, we're talking about just a small little part of the addiction epidemic. I should say, actually, addiction is an endemic. It's part of our makeup as human beings. I think it's always been with us as a species. The opioid use part of it is experiencing a spike right now, partly as a result of the iatrogenic pharmaceutical marketing in the 90s, but also because opioids have always been a favorite drug for self-medicating among humans. And these are some of the adverse pregnancy effects that are specifically attributed to substance use generally among pregnant women. So bad things happen in pregnancy. So abruptio placenta, fetal death, infection, growth restriction, preeclampsia, placental insufficiency, postpartum hemorrhage, thrombophlebitis, all kinds of terrible things can happen. But you see there, the ones that we primarily were worried about in this patient that I just talked about was premature labor and delivery. So it's the hypercontractility that happens in muscles during opioid withdrawal also affects the uterus. The uterus can start to contract and push a baby out sooner than it ought to. So that's a big reason for treating it. Those are mostly not specific to opioids, right? The muscle contractility presumably is, but the flood of catecholamines can happen to somebody in withdrawal from any drug. So polysubstance use is often accompanies opioid use, and tobacco use specifically is about 4 times higher in opioid users than in non-users. Poor nutrition, low socioeconomic status, as precious resources are spent on expensive and illegal drugs, there are fewer resources. People's poverty tends to intensify as they get trapped more and more into the cycle of drug use. There's often many comorbid disorders, specifically psychiatric disorders. Women often don't get adequate prenatal care. So there's lots of other things that set a woman up for all of those bad outcomes, like preeclampsia and placental abruption. It's not solely due to opioids. Right? So another thing that we all need to remind ourselves, I'm sure, or maybe we don't, pure medical grade opioids delivered in a safe and measured way aren't particularly harmful. Much of the damage that occurs to women who are dependent on opioids or dependent on any other drug that is deemed illegal is because the drug she's dependent on is illegal, and because her life and the poverty that she lives in are criminalized. So the group in Kingston, which was interested in trying to address and marshal resources for women with addiction, did a needs survey to look at the level of substance use and opioid use in our community. We did a survey of women who attended opioid agonist clinics. So not surprisingly, these were 67 women who were surveyed. 85% of them reported opioid use. You might wonder, why didn't 100% if they were coming to an opioid agonist clinic? Well, one of the clinics that they attended was also a safe, not a safe injection site, but it was a needle exchange site at that time. So people would come there presumably even if they weren't opioid users. More than half reported marijuana use, and remember, this was before legalization. Half reported methamphetamine use. So just a little refresher of what I said about the specific effects of opioids. The opioid withdrawal in a mother, the similar thing happens to a baby. Right? So a mother gets respiratory, she gets tachypnic and has a flood of catecholamines. The baby does as well. Those things alternating between intoxication and withdrawal, which happens typically with the use of high doses of short-acting opioids that are used in a means that gets to the brain quickly. So you alternate between tachypnea and respiratory depression. It messes with uterine blood flow and it interferes with placental function. Long-term, beyond pregnancy, there are various studies which have shown the association of developmental delay and neurocognitive deficits attached to babies who are raised by mothers with opioid use disorder, but it's very difficult to say to what extent those are really caused by opioids and how many of them are caused by the associated factors that go along with criminalized opioid use. So the adverse neonatal effects specifically, so once a baby is born, we're dealing with a baby who often is growth restricted, is born premature, and then experiences neonatal abstinence syndrome. So the NAS, which I will be the subject of most of the rest of my talk. And basically, NAS in babies is just withdrawal syndrome. It's a COW score for babies. You have a baby who has some respiratory distress, is tachypnic, has increased tone, is very tense and tremoring, and at worst can have seizures. So unlike in adults, opioid withdrawal in infants can be fatal. Babies won't feed well, so they lose further weight. And then there's autonomic dysfunction, sweating, inability to maintain a steady temperature, body temperature. And I just want to allude to this paper that was published by Susan, lead author was Susan Broglie out of Kingston, who looked at opioid use among pregnant women, specifically in Ontario. So it was a bit of a groundbreaking paper. It's now a bit out of date, I'm afraid. So this shows increasing rates of neonatal abstinence syndrome during the period that she was looking at. But in fact, since then, you can see this increase. So 0.99 per thousand live births. It's gone up. So the most recent data, again, in the study, the paper by Piskey that I referred to in pediatrics, and I will provide the references along with this slide deck. The most recent data we have are 7.3 per thousand birth hospitalizations. So you can see that's been increasing steadily over the past 15 years. So when we looked at, so in this paper, when we looked at those women, so in that 12-year period from 2002 to 2014, there are these interesting features that we picked up demographically. So women who reported opioid use in pregnancy were way overrepresented from the lowest socioeconomic quintile. Many of them took psychotropic medications and had concurrent disorders. Sorry, this is a bit choppy. That wasn't a very smooth segue. What I'm saying now is that I just want to leap into the appropriate treatment for opioid use disorder in pregnant women. So since 2011, it's been recognized that the treatment of choice, the standard of care for women who are dependent on opioids during pregnancy, is that they should be offered substitution therapy in the form of opioid agonist therapy, and not detoxification, because again, we know this in adults who aren't pregnant, that attempting to detoxify people has a very high rate of causing relapse, overdose death, and infection. In pregnant women, those things are all true too, as well as preterm labor. So the standard of care is opioid substitution therapy. That's what it was called back in 2011. Like many things, it seems to me, in addiction medicine, the acronyms change very quickly. Now we would refer to this as opioid agonist therapy, and we use methadone and buprenorphine. So this, bear with me, this talk was originally organized for a general audience who may not be familiar with opioid agonist therapy. I'm sure all of you are, so I'm going to jump over some of this. The benefits of OAT, of course, are especially well proven in pregnancy. So basically and I can say just from anecdotal evidence, it's glaringly obvious that putting women who are using illegal opioids or using opioids illegally on OAT results in a very much higher rate of full-term pregnancies and healthy birth weights and good outcomes in the short term. Methadone versus buprenorphine, there isn't really statistical evidence proving that buprenorphine is better, but I think everybody who treats women with opioid use disorder believes that buprenorphine is better and has seen it have less of an effect on babies and cause less prolonged and less severe neonatal abstinence syndrome in babies. So the thing about OAT, though, of course, one of the objections to it that many patients raise is, well, it's just trading one drug for another. You're just going to make me dependent on methadone or buprenorphine. That's stupid. I want to get off. I want to be free of drugs. Indeed, that's the whole point. Opioid agonist therapy perpetuates opioid dependence, but it does it in a safe way that doesn't result in death, hopefully, and allows a person to live a longer and healthier life. And if they choose eventually to taper off and stop using opioids, but that's not the immediate point. And the reason that's relevant in babies is because during the pregnancy, mothers are often very, very keen, and they endorse the desire to come off of opioids. But you have to point out that, right now you're 4 months pregnant, you have 5 more months. The chances that you're going to be able to get off opioids and stay off them before the baby is born, I hate to say it, are pretty low. So your baby is probably going to be getting opioids whether you like it or not. And for your safety, my advice as a physician is you should stay on opioid agonist therapy. You should get it in a way so that you don't have to experience withdrawal and you don't put yourself in danger. And yes, the baby's going to be dependent. Yes, the baby's going to be exposed to the risk of withdrawal, but we can get through it. You'll be able to room in. You don't have to worry about being separated from your baby, because that you can well appreciate that having a nice, supportive, positive talk with a woman about how addiction isn't your fault, it's a disease, you can't help it, you're dependent on opioids, we're going to give you OAT, and then as soon as your baby's born, we're going to take it away and put it in the nursery. Really comes across as however you do it, and however friendly and careful and caring and non-judgmental you are, that's a very shaming and distressing experience for a woman to have her baby have to be cared for in the NICU. So happily, we don't have to do that. And so it's the question, so that I think I've just addressed that. Optimal dose important to avoid complications. Yeah, I mean, the hopefully one, if over the course of a conversation with a woman over several visits, often women will come in adamant about not increasing their OAT dose. But if you point out to them, well, the whole point of you being on OAT is so that you're not miserable, and you shouldn't be feeling withdrawal because you're not going to be happy and you're not going to feel well and you're going to be tempted to use. And the baby isn't going to be happy if its mother isn't happy. That's kind of simplistic, but essentially it's true. The point of optimizing OAT dose is to make the mother as comfortable and to feel as well as possible, because she will be in a much better psychological and physical state to care for her infant. So yes, we certainly make that very clear. And no, there's no maximum dose, except, I mean, other than the maximums that I think we all tend to work around now. High dose methadone is over 90 or 100 milligrams. Buprenorphine, we tend not to prescribe more than 24 or 32 milligrams to a person in a day. There's no difference for pregnancy. So we wouldn't treat a pregnant woman any different than a non-pregnant woman, except that it's not unusual for a pregnant woman on methadone in the third trimester to experience what seems to be a subjective decrease in the effectiveness of her methadone because of her increased blood volume and the volume of distribution and protein binding and a lot of other things. The efficacy of methadone decreases as you get pregnant, as you go progress in your pregnancy. So it's not unusual to have to increase a woman's methadone dose in pregnancy. Happily, that doesn't happen with buprenorphine. That's another reason buprenorphine is so much preferred for opioid use disorder in pregnancy over methadone. So here is the COWS score for babies, the Finnegan score. This is what we used to use obsessively. We would test babies every 4 hours and we would chart their symptoms. And if their symptoms rose above 8, we would deem them to be in severe withdrawal and we would treat them with morphine. And typically that only happens in the NICU, which is why babies had to be in the NICU. Yeah, so I'm just comparing it with the COWS score. So this is where things were at in Kingston before 2013. So a baby would be born, the mother would get to cuddle it for an hour, and then we whisk it away, put it in the NICU and start watching it. And about 80% of babies, so 80% actually had Finnegan scores higher than 8, which was the rate at which they were given morphine. So about 80% of the babies born to opioid-dependent mothers had to be treated with morphine. And there was lots of talk at the time and lots of evidence accumulating, led to a large part by Ron Abrahams and the group in BC at Women and Children's Hospital, that in fact, a lot of the high Finnegan scores are caused by, remember there's subjective, and I talked about that father coming down from his northern community. He doesn't speak English as his first language. He's alone. He's worried about his kid. His COWS score is high. Well, the same is true if you take a little newborn baby and you put it in a bassinet with bright lights and nurses wearing plastic gloves poking at it, and it's not being cuddled by its mother, it's going to show signs of stress, and that will show up on the Finnegan score as a high Finnegan score, which means that it's likely to need treatment with morphine. So finally, by around 2010, there was starting to be articles like this published saying it's probably safe to leave opioid-dependent babies with their mothers. So our group in Kingston made this argument to our administration, and we put together a task force, and we met regularly. And over the course of 3 years, we were able to do this. So we finally did a pilot project. We stopped in the middle of 2013 admitting babies directly to the NICU, and instead we gave their mothers a private room, left the mother and baby together. Private room so that there wasn't a lot of noise and stimulation and people wandering in and out. And lo and behold, average length of stay went down from 24 days to 8 days. And the number of babies requiring methadone dropped from 20 out of 24 to 3 out of 21. So dropped from 80% to 14%. And sorry, now there's another question. Do you find split dosing less necessary with buprenorphine than methadone? How early do you start splitting methadone doses? Can you speak a bit about maintaining even blood levels, benefits for moms and babies? So no, it doesn't seem to be necessary to ever split a dose with buprenorphine. So I haven't done that exclusively for, I mean, there are women our study, notably, one of the limits of our study is that we included all comers. So any woman who was on an opioid for any reason, and many of them were actually not people with substance use disorder, they were people with chronic pain. They tended to use split doses of buprenorphine because they had chronic pain. That was not, though, to stave off withdrawal, and it wasn't necessary as far as we could see. So there seemed to be no difference in the mothers who had split doses versus the mothers who were on a steady single dose. As for the methadone, it was really up to because until the time a woman was admitted to the hospital, she was being cared for by an OAT clinic in the community, and they had rules about whether they would split doses. Typically in Kingston, none of the clinics would easily split doses. A woman who was given carries could do that on her own, but that was more something, a discussion left up to her and her methadone provider. So the study that we published was included in this meta-analysis, which concluded that just as since 2010 we've been recommending that OAT should be the standard of care for pregnant women with opioid use disorder, so now should we be recommending that if it is possible to do it, you should let a baby room in with its mother. You should not separate a baby from its mother. You will have better outcomes. And we just recently published, so the reason I said this is 5 years of experience, because we recently published the data from the last 5 years, which happily worked out to be exactly 100 babies born to 84 different women. Okay, sorry. What I'm showing here is that part of the reason our rate of needing morphine was so high, and these numbers are a little bit different. You see here, it says the NICU group under McKnight's study was 83% versus 15%. In the last 5 years, it's averaged only 3.5%. So in fact, only 2 of the babies out of the 57 who roomed in required treatment with morphine. So it's now exceedingly rare. If you leave a baby with its mother, it just doesn't show withdrawal so severe that it can't be calmed and it can't be helped to feed. So you don't need to treat it with morphine. And keep in mind that one of the reasons I alluded to before, that morphine is such a popular drug of use and misuse among humans, is that it calms you down no matter what your problem is. If you're upset and worried and depressed and you take morphine, you'll likely feel better. And that was true of the babies too. So we thought that giving them morphine and seeing a decrease in the Finnegan score was proof that they were in distress because of their withdrawal from morphine. In fact, a baby in withdrawal from its mother given morphine learns that they can be pleasant and happy and relaxed. And that's not a good thing to teach a baby who's already been delivered to a woman who probably carries a genetic load for addiction, if you think about it. So the conclusions, so I think what I just wanted to point out here was that only 3.5% of the infants who roomed in needed treatment with morphine. But among the babies who were admitted to the NICU, 44% needed treatment with morphine. So they're apples and oranges, because the babies who went to the NICU were sent there for reasons other than the fact that their mothers were on opioids. And that didn't used to be the fact. Right? Up to 2013, all babies born to opioid-dependent women were sent to the NICU. Now we only sent them there if there was a reason for them to be in the NICU. So if they were born premature, if they had birth trauma, if there was some fetal anomaly, if they had respiratory depression and they needed support with CPAP or BiPAP, then they were sent to the NICU. And those babies did have a higher rate of needing morphine. So you see 44% is still lower than the 80% of the general population. Whether that's because these are really truly sicker babies who maybe don't tolerate withdrawal as much, or it's partly because the nurses were getting a little bit more lenient and not as nervous about starting on morphine because they had appreciated. So the hospital culture changed, right? They knew, well, the babies who go up to Kid 10 to the pediatrics floor don't need morphine for their opioid withdrawal. Maybe this baby isn't distressed because of opioid withdrawal. So I think we actually lost some of our keenness to start morphine on babies. Women who, again, I referred to polysubstance use being a confounding factor. So women who took benzos, who used other illicit drugs, and who didn't breastfeed tended to have babies who were more likely to require morphine. And that was whether or not they roomed in. So all of those things seem to have some effect on a baby's ability to regulate itself and to tolerate withdrawal. And I think we're getting close to the end of the time here. So just to end up, I'm going to run through this. So just demographically, looking at this population of 84 women who used substances during pregnancy, 23% were actually taking benzodiazepines, 51% took other prescribed medications, usually psychotropic medications. So again, remember in the population study from the JOGC that Susan Broglie authored from 2002 to 2016, 2014, a high proportion of women had concurrent disorders and were treated for psychiatric illness. That seemed to be the same, seemed to be borne out among our population as well. And then significant comorbidities. So a couple of people have alluded in the chats here about how lucky we are to have a hospital that supported this. To be frank, I mean, the hospital is just a big institution, and if there's enough people within a hospital who decide to do something, people, may not stand in your way. And there was a bunch of, it was lucky that at KGH we had a few people who were like-minded, and we all wanted to try to work together. So I had the privilege of working with a nurse practitioner and a social worker and a community family support worker, and all of us had the same idea, which was decrease all of the stress on pregnant women, make things easier for her, and make things easier for the baby, and probably things will get better. And lo and behold, it did. Sorry, I've just reminded that actually we have 15 more minutes, so I will slow down a little bit. And just again, to allude to the paper that we published, I want to just show a little bit of the data that we got from that. So this is the paper that the group of us in Kingston, so it was me and Susan Broglie actually was also one of the contributors to this, and a dietitian and a social worker who worked at methadone clinics. We asked women, so beyond all of the other things that occur during your struggle with substance use disorder while you're parenting kids, why would you, are there reasons that you wouldn't ever have been able to attend treatment, right? The gold standard of treatment for addiction generally, not just for opioid use disorder, is residential treatment, intensive treatment. And most women hadn't had the chance to experience that or hadn't taken advantage of the ability to experience it. And when we asked them why, you can see the two big bars here together, fear of losing their children and no care for their children. So of course we know that to actually have to fess up and go to a treatment center and say, look, I have an addiction and I don't think I can handle it and I need to come in for treatment. They're told that they can't bring their children with them. They have to leave their kids somewhere. And that was a big reason for women to never consider going to residential treatment in the first place. The nice thing about rooming in is that it's a kind of little tiny microcosm. It allows essentially, it's treatment for both the mother and the baby. And it allowed the mother to stay put and for the baby to be with her. And look how much better it was for the mother and baby. So we thought that probably is true for mothers and older children as well. So fear of losing children, 66%, no one available to care, it was 49%. And using that approach, we hope someday to be able to expand the principles, that the philosophy underlying rooming in, to women of all ages, people who have children of all ages who are trying to recover from addiction, is that they should be able to get treatment for their addiction without having to jeopardize or break the bond with their children. So we use a biopsychosocial spiritual approach. We treat the mother-infant as a dyad, and that really still is something we have to fight to do at our hospital. As wonderful as it's been to be at KGH, there still is some pushback when we want to keep a woman in the hospital so that she can continue getting meals and medication dispensed to her. administration wants to discharge her after 24 hours because she doesn't really need, quote unquote, need care. We have to reassert. Just this past week, I had to go back to the nursing administration and say, well, actually, she's part of the care team. She's caring for the baby. If we don't give the mother food, if we don't let her stay in the hospital, the baby's not going to do well. And then we're going to have the baby in the NICU for 2 weeks. Do you really want that? So it's something we have to continue to push against. The question now comes up, did you also collect data on the mother's experience? We did for the first cohort that roomed in. And that was gratifying to see. So many of the women who roomed in had children previously under non-rooming in conditions, and they were all very enthusiastic about the comparison, about being able to, I mean, it was a very empowering, positive experience to be treated like a regular mother and to be allowed to I still use this language as though we're doing them a great favor, allowing them to care for their babies. When we realized that we weren't endangering babies by leaving them with their mothers, we backed off, we left them alone. Mothers would breastfeed, mothers would cuddle their babies, mothers would lie after the babies, and they would do just as well as other mothers. And in fact, in that first cohort, more mothers fed their babies for some proportion of the time with breast milk. So the number of mothers who gave their babies any breast milk was 83% among the mothers who roomed in. The general population for that same year, that same cohort, was about 78%. So if anything, once these women were given the room and the space and the support to do it, they proved to be even a little bit more eager to try natural childcare methods and to provide the babies with breast milk and to do a very good job. What was helpful from the administrative perspective, I have to say, is that this cost no money. It required no special training, and it essentially saved the hospital hundreds of thousands of dollars overnight without any investment. And that has remained the case. Unfortunately, one of the reasons that we published our data after 5 years is because the hospital was getting a bit complacent, and they'd sort of forgotten that this was a huge money-saving effort that was saving resources at the hospital. And like I said, was starting to get a little bit pushy about sometimes wanting to discharge mothers again. And I thought we needed to remind them, this will not go well if you don't support these mothers. And sorry, so the question about mothers who are on OAT and are afraid of breastfeeding, we can point to lots of data now, lots of evidence that says that breastfeeding is safe in mothers who are on methadone and buprenorphine. And I think people are more reassured by hearing a person's anecdotal experience. I could say to them, look, I've seen mothers do this for 5 years and breastfeeding goes well, and there's no reason you can't breastfeed. So that's the message that we repeat over and over again. And that again speaks to this final conclusion: strengthening and supporting a mother-infant bond is our primary objective. And my gosh, so the follow-up question, would any buprenorphine get through breast milk and possibly help with NAS, is always the corollary to that. No, it doesn't. Yes, probably some gets into the breast milk, but not to a significant degree. As far as we can tell, the benefits of breastfeeding to a baby whose mother was on methadone and buprenorphine or buprenorphine is not because it's getting a little tiny bit of methadone or buprenorphine in the breast milk. It's because it's getting breastfed. And babies who are breastfed are happier. They do better, they have better immune systems, they have better neurodevelopment. Everything is better if you breastfeed. So it's not because they get a little, we're sneaking in a little bit of opioid agonist therapy for the baby. So, yeah, so one of the reasons that I'm eager to give this presentation over and over and over again is because it should be an option at every hospital. It makes no sense to me at all that we do this expensive iatrogenic harm to babies who are dependent on opioids. We take them away from their mothers, we make their withdrawal experience worse, then we teach them at their first experience of life, you're in distress, here's something that'll help. Morphine. That's not a good message that we want to be giving newborn babies who are born with a genetic predisposition to addiction, possibly into families that might also have psychological environments that are going to put them at risk of developing addiction.
Well, that was wonderful. Thank you. There are about 7 more minutes left to our talk today. And I know Dr. Adam Newman is really happy to answer questions. So if you do have any questions, please keep going with them in the chat like you guys have been doing. I know there was one question that was thrown out earlier about alcohol use disorder. If you also
Right.
treat
Sorry, I skipped over that.
No worries.
It's interesting that, one limitation about anything that's published out of Kingston is a weird little town. And for some reason, none of the 120, well, now 140 odd women that we cared for over those 6 years who had substance use disorder, none of them endorsed drinking alcohol. And of course, it's hard to objectively verify. But there didn't seem. I can't say that it looked suspicious to me that women were just saying that because they didn't want to have another reason to be judged and thought to be bad mothers. So they said, no, I don't drink any alcohol. It really did seem as though the women who were identified as having opioid use disorder didn't also use alcohol. In my community practice, I have had a couple of women referred to me whose primary addiction was to alcohol, but it's really only a couple. And anecdotally, and this is worth nothing, right? This is not evidence. Those couple of women abstained from alcohol once they passed the threshold of having their primary care physician send them to an addiction doctor while they're pregnant. So I think that that switches something in an addicted person's mind, like, oh, this is now out of the closet. It's not a secret anymore. I really have to do something about this. I have to stop somehow. And happily for the two women that I'm talking about, they had other social supports come together for them, so they were able to stop drinking and able to do something else instead. One of those two women did use anti-craving medication. One of them didn't. I think that means that the one who didn't really qualify for severe alcohol use disorder and isn't somebody who would have identified as an alcoholic. The other one made use of anti-craving medication. So I really don't have a lot of experience treating alcohol use disorder in pregnancy. So then there's a question. So what would be the best answer for women in the community planning to get pregnant and wanting to taper OAT? Well, there's been a couple of Canadian papers published recently in the JOGC on the experience of women on OAT during pregnancy and around contraception. So that clearly there are people who are paying attention to this. Generally, other than being pregnant and being being women who are of reproductive age, or being people who are capable of getting pregnant and are of reproductive age, there's nothing special about addiction in that cohort of people. Just as it's individualized. Why we have to have some instinctive sense when we're dealing with a patient. Is this somebody who could realistically do well coming off of opioids altogether and shouldn't be on OAT? Then, of course, we never refused. I've never refused to lower somebody's OAT dose. If they're adamant and they want to come off OAT, they got to come off OAT. That's part of the deal. That's part of them learning to be responsible and take responsibility for the disease. I'll taper them off OAT. But I generally try to tell somebody, don't put a whole lot of undue pressure on you. You're only going to be pregnant for 9 months. You got a whole lot of other stuff you got to do while you're pregnant, because typically these women would also be starting to deal with their dysfunctional relationship with the father of the pregnancy, their insecure housing, income. There's all kinds of other things that they have to deal with. And sometimes giving them permission, saying, look, why don't you just not worry about your OAT for the moment, and later on you can come off it, because I promise you it's not going to be bad for your baby. It's not going to damage your baby's brain. It's going to be much safer and better for your baby. Your baby will do well, especially if the alternative is to accidentally relapse to opioid use disorder. right? I mean, the thing that a person with addiction is really asking you when they say, I'd like to not be on methadone or buprenorphine anymore, is they're saying, I'd like to not be an addict anymore. Like, could we just arrange that, please? And you have to say, look, you have addiction. Somehow it came to be. This is part of who you are. If we decrease your opioid, your OAT, we know statistically that people like you who have addiction are more likely to resort to dangerous means of getting opioids, and it's dangerous and it'll kill you and it could cause an infection that will harm your baby. I'm sorry, that's the way it is. You're an addict. I mean, I use that term because I call myself an addict, but we don't use that that sounds kind of judgy and stigmatizing, but you have the disease of addiction. It's like telling a diabetic woman who wants to come off insulin because she doesn't like the idea of taking insulin during pregnancy. Well, I'm sorry, you're still going to be diabetic. Yes, sorry, somebody just mentioned Nikki Bozanoff's poster, which I did look at. Yeah, and basically the upshot of that, I think, was that the longer you take to taper somebody off, the better. And I certainly have tapered women during pregnancy, but I've always said here, the cutoff is going to be, we don't want to taper you so fast that you start to feel withdrawal. Okay, so we'll drop your dose by some amount. I'll see you in a couple of weeks. If you're feeling withdrawal, tell me, and we'll hold it there, or we can go back. But let's taper you as long as you don't feel it.
In the 1 minute left, I don't know if you want to highlight, there's 2 questions you haven't hit on. You've done a fantastic job of getting those questions otherwise, about OAT in pregnant women versus not pregnant women,
Right.
and then one about Cadian.
Okay, so about is it advised to start OAT induction in withdrawal center? I assume you mean in a hospital. No, it's not. It doesn't have to be done, but if you can do it and the woman is willing to do it, it's very nice to have that option. And we used to do that typically before we knew about microdosing. So if we brought a woman in to put her on buprenorphine and she had to be in a little bit of withdrawal and she was in her 3rd trimester, we would not do that as somebody out in the community. Nowadays with microdosing, you could do that in the community. And we would also typically only do it in the hospital in later trimester, in 3rd trimester. And then Katie, I can't speak about Katie in pregnancy because I think I looked after one woman who was on SROM and methadone, but everything else about her life was a disaster. She was living in a shelter. Her boyfriend was abusive. She had 6 previous kids who were all put in care. Nothing went well in her pregnancy. And so that's anecdotally, that's the only experience I have of a pregnant woman with on Cadian. I'm sure Suzanne Turner would be able to tell you 100,000 things about that.
Appreciate your time and answering all of those questions. Thank you everyone for being here and asking those questions. I know Dr. Newman has already shared his email, so hopefully a lot of people will be reaching out. And now you're on a break for the next 15 minutes before you get to choose which session you're going to jump into next. So thank you everyone. Thank you, Dr. Newman.